All right, I think we're going to move on now to Dr. Larry Saidman, a close friend and researcher with Dr. Eager. He's a professor emeritus of anesthesiology from Stanford, formerly chair at UC San Diego.
Happy Groundhog's Day, everyone. A confession. There are going to be a number of similarities that you'll hear between Ted's career and mine and our lives together. And one of which is when, as a high school student, I too got a job selling women's shoes. Not at Mailings, which was right down the street from it, but Allen's shoe store. But unlike Ted, I loved the job. Not because I wanted to be a lifetime shoe salesman, but it was the first opportunity that I'd had to deal with the public, to learn to deal with people that I didn't know. And that was an amazing experience in terms of being able to sell myself to strangers who, yes, they wanted to try on a lot of shoes, but it was my job to try and convince them that they looked just gorgeous on their feet. The shoes were $199, $299, and $399. So you had to sell a lot of pairs of shoes to make any money at all during the Saturday. And I confess I did like the job. And whenever there were vacations, I'd come home from school and I would go down and work on a Saturday at Allen's shoe store. This is entitled My Last TED Talk. I've always wanted to give a TED Talk. Perhaps not necessarily this one, but it seemed like an appropriate title. I was, as you can see, a professor at emeritus. I am a professor emeritus at both UCSD and Stanford. And in order to have two designations like that, you just have to live long enough. And obviously I have. Graduating from med school in 1961. And actually this picture was taken several years ago. The outline of my presentation, I'm going to provide some stories highlighting my relationship to Ted that has spanned more than 55 years and how these stories fit in with the development of the specialty during which some have described as the golden age of anesthesia. It's traditional at the start of an eponymous symposium or talk to provide an audience of just how the lecturer, and in this case the individual for whom the symposium is named, are related. We were both born in the 30s, an interesting decade highlighted, of course, by the Depression. But it also had, as a consequence of the Depression, the smallest cohort by far of births between 1910 and 1950. Now this, of course, have resulted in a relatively small cohort of individuals later on selecting medical school and increased the likelihood of acceptance, and I suspect that this had some role in my being accepted to medical school at the University of Michigan. This was described in some detail by Malcolm Gladwell in his book, and the chapter Outliers, in his book Outliers. As a medical student, I knew nothing of the specialty, other than there was no night call. Anesthesia was a surgery elective at the University of Michigan, and because there was no night call, and the various surgical subspecialties were selected from a deck of cards, with an ace drawing their being getting the highest choice. I drew an ace, and I chose anesthesia. And similar in some respects to the epiphany that Ted had when the patient stopped breathing, my first experience also nearly hooked me into this specialty. Was this a good choice? One might ask. There weren't that many of us in anesthesia at the time, and we were not well thought of. This is a description on the left-hand side, the year or the decade, the number of board-certified anesthesiologists in the middle, and actually since the American board was formed in 1940, there obviously weren't going to be a great number. On the right-hand column are the number of anesthesiologists per million of the U.S. population. As you can see, in 1960, there was one anesthesiologist approximately for 76,000 Americans. The certificate number for certification, Ted's was 2531, and mine was 3967. He was 6 years older than me, and that represented 6 years of certification. This number of anesthesiologists obviously has increased substantially to 2,000 to the present, and there is somewhat greater than 1 per 6,000 American citizens now, compared with 1 to 76,000 when the two of us were certified. Who went into anesthesia? There's a number of quotes from dignitaries in the specialty describing individuals going into anesthesia. This first one is from a chapter in the book that you had seen before, The Wondrous Story of Anesthesia, about which I'll speak a little bit later. This was a history of women in American anesthesia. And this is Waters writing to Goodell. Although his first 2 trainees were women and 3 of the first 6 were women, Waters wrote to Goodell, "MD ladies are useless in the profession. I am through with them. Ladies are nice socially, but not professionals." John Lundy described who went into anesthesia. There was a tendency for only those physicians who were incompetent in general practice or in other branches to limit themselves to the practice of anesthesia. Henry Beecher, then chairman at Mass General, described anesthesia technique can be mastered by ordinary men who are ordinarily deft, with only a modest requirement of intelligence and knowledge and judgment. And he was the chairman. Stu Cullen, my chairman here at UC when I became a resident in '62, commented, "There exists a widespread sense of inferiority among anesthesiologists as they compare themselves with other specialists. This attitude interferes with recruitment." And finally, Forrest Leffingwell, who was president of ASA in 1961, says the specialty is so subject to underrating and disparagement by the uninformed that it is often difficult to convince potential trainees it is a desirable and dignified pursuit for a physician. However, we ourselves could be responsible for the light in which others see us. I knew nothing of the specialty. I had no funds to visit programs as compared with residents nowadays, not necessarily having more funds, but perhaps a lot more debt. But I looked through the Green Book, the famous Green Book of internships and residencies, decided that a 3-year program was better than a 2-year program. I asked my wife, who's made many of the major decisions and the important ones in our family. We'd never been to San Francisco. Where would you like to go? New York, Pennsylvania, Philadelphia, or San Francisco? And as I said, as we'd never been to San Francisco, she said, let's go there. And that was my recruitment to anesthesia at UCSF. On the summer of my internship, I received a phone call in the afternoon. I had just been on call at my internship. It was Stu Cullen on the phone. He said, we want you to come be a resident at the University of California. I said, fine. That was the total process by which you became a resident. We had never been to San Francisco and obviously knew nothing about the department. It was the right place at the right time, however, and that's when I met Ted Eager. My first meeting with Ted was in July of 1962. He was my attending on a series of cases, And without any preparation, and in between cases, I was subjected to a Socratic style, and those of you who've been Ted's student in the past will understand what I'm saying, a Socratic style oral examination, testing my knowledge of the gas laws from inorganic chemistry in my second year of college. So I had to expound on Boyle's law and Gay-Lussac's law and Dalton's law of partial pressures, etc. And obviously I must have passed, because the next thing I knew, I was being asked if I wanted to help perform the first MAC study in humans. And this is who I got an opportunity to work with. This is John Seringhouse in Ted's laboratory on the 13th floor of the Moffitt Hospital. And from left to right is Dick Shargell, who was a technician. Cedric Bainton, who was a fellow resident of mine, is in the audience. That third guy with a bunch of hair is me. The fourth one was Bob Mitchell, an internist interested in the control of breathing, with whom Bainton worked. Freeman Bradley, who along with John devised and put together the first multifunction blood gas machine. Ted Eager. To Ted's left is Ed Munson, who is a subsequent, he was a fellow with Ted. And over on the right is John Seringhouse and his secretary, and Dorothy Herbert, his technician. I was the fourth fellow that was asked to work with Ted. The first was Phil Larson, who went on to become chairman at Stanford University and later editor-in-chief of anesthesiology. Bernard Brandstater, who at the time was the chairman of anesthesia at the American University in Beirut. Giles Merkel, who was a resident with Ted and performed the first MAC study in animals. And finally, I was participating in the first MAC study in humans. And what an opportunity. Talk about good luck, good fortune. Well, I'll get to it. In the meantime, I should point out this book had just been published. This was a book describing pretty much the first book on uptake and distribution of anesthetic agents. The book had not quite yet been published, but his chapters were in it. And as he was hooked by, I forgot which of his teachers in high school, to mathematics, I was hooked to pharmacokinetics of inhaled agents. In any event, my first anesthesia paper was the paper that resulted from this human MAC study conducted along with Ted. It described the effect of nitrous oxide and narcotic premedication on the alveolar concentration of halothane required for anesthesia. The paper won the first prize in the ASA Residency Research Contest, first prize in the CSA Residency Research Contest, and was included in the 100 most highly cited anesthesia papers. Why is MAC important? MAC is important, MAC being the alveolar concentration, virtually eliminates the likelihood of movement in response to a skin incision. If you're careful enough to maintain the alveolar concentration above MAC, an incision will prevent the patient from moving. Some have said, I think it might be John Seringhouse, matter of fact, who's here, that MAC actually, rather than being an acronym for minimum alveolar concentration, was the response a surgeon would make when an incision occurred and the alveolar concentration wasn't sufficiently high. The surgeon would announce, MAC, hey MAC, the patient's moving. It also should prevent awareness, and if you're careful to maintain the alveolar concentration at a certain level, it'll prevent movement in response to tracheal intubation, and as well as the blood pressure response to intubation. These are the data from that first MAC study. The data were reproduced as a cover on of journal Anesthesiology several years ago, and from top to bottom, You can see that the three cohorts of patients, Group A, Group B, and Group C from top to bottom. On the your right-hand side are the responses to the skin incisions of the various patients that were anesthetized. A line going above the horizontal indicated the patient moved. A line going down from the horizontal indicates the patient didn't move. And where these two cohorts of patients, those that moved and didn't move, overlap, the term MAC was derived. The Group A represented patients anesthetized with only halothane and oxygen. And MAC at that point was about 0.76%. The second line, remember the practice of anesthesia pretty much involved pre-medication given to patients. There was some question as to whether giving a pre-medication reduced the concentration required for anesthesia. And what we showed was in patients that received a small dose of either an opioid or a hypnotic, there was about a 10% reduction in MAC. It did take less anesthesia, but not a great amount. Finally, the bottom line were patients anesthetized with halothane and oxygen and 70% nitrous oxide. And as you can see, there's a dramatic reduction to the left when nitrous oxide is added, somewhere between 60 and 70% reduction in the amount of halothane that's required. Now let me tell you, there's a famous well-known newscaster from some years ago whose name was Paul Harvey, and he would always tell a story, and then at the end of the story he'd say, "Now let me tell you the rest of the story," or "Now you know the rest of the story." I'm going to tell you the rest of a story here that nobody else knows except Dr. Eager and myself, and I'm the last one standing. There were two papers published in the early 1960s. Actually, there are two papers describing the same subject, both written by Denborough from Australia, Melbourne, in which he describes anesthetic deaths in a family. The first publication was only a paragraph or so, and was published in The Lancet as a letter to the editor. It drew no attention. 2 years later, in 1962, he wrote a more complete paper, pretty much of a case report, again describing anesthetic deaths in a family. He describes several generations of a family of 38, each of whom had received ether or halothane for mostly minor surgeries. 10 of these patients died during or following general anesthesia. The pattern of inheritance was considered compatible with that due to incomplete penetrant of a dominant gene or genes. The three best documented cases, or the documented deaths, died 30 minutes post-operatively following seizures at high temperature, as high as 42 degrees centigrade. The autopsies were normal. This is a description of the 38 patients. Those, you may not be able to see it too clearly. The dark spots or the dark knots are the patients who died. Now here are the data again reproduced in a somewhat less clear fashion. And again, you can see that there is a Group A, a Group B, and a Group C. What you don't see are Group D. What I haven't told you, but was included in our paper, is that there were 4 patients who received a different anesthetic protocol. Here you can see that MAC was determined from a cohort of patients. It required, since each patient only had one response, a fairly large number of patients had to be anesthetized and their responses logged so that a definitive number could be achieved. We were interested in testing MAC or determining MAC in each patient. And what we did is we approached a patient and said we were going to anesthetize them for several hours prior to surgery and determine the precise amount of anesthesia that they needed. They were attracted by that, and so we did just that. Patients were brought down to the operating room and were anesthetized for several hours, as long as 4 hours, anesthetizing first at a concentration that prevented movement, and then decreasing the concentration in steps to a point where they just moved, and then increasing it again in steps to the point where they didn't move. And the point that between the movement and no movement was defined as MAC in that patient, and wouldn't you know it, it was exactly the same as the MAC that we had determined in the larger cohort of patients. The unintended consequence occurred in a patient in Group D. He was a 47-year-old man, weighed 98.5 kilos, 173 centimeters tall, somewhat obese with a BMI of 33, and was scheduled for a ventral hernia repair. He'd received halothane for 4 hours as part of a Group D MAC study, after which we brought him to the operating room, added nitrous oxide, and he continued to receive halothane. And at that time, we provided muscle relaxation using succinylcholine as an infusion. Things were a little different then. The surgeon was a guy by the name of Grimes. Some of you may remember him. He was an interesting surgeon with a certain amount of flash and temper, and demanded profound muscle relaxation. And this hernia required a lot of relaxation. We left the operating room, Ted and I left the operating room because our part of the study was done, and the patient was left under the care of the attending anesthesiologist and resident. And we were called back shortly after we left with the attending, who happened to have been Neri Guadani. This patient is sweating. We're not able to provide relaxation, even with increasing doses of succinylcholine. The blood pressure is decreased so that it's nearly unobtainable, and there's a tachycardia. The temperature at the time was 101. It increased to 108.5 over the next 30 minutes, and we obtained a blood gas in which the pH was 6.8, the PCO2 was 179, the PO2 was 143, and the base deficit was more than 14. Anesthesia was discontinued, the patient was packed in ice, sodium bicarbonate was given to treat the acidosis. The temperature fortunately decreased over an hour, and to normal over to 33, and to normal over an hour more. The patient awoke intact, no neurologic damage, and as far as we're concerned, this was just a what happened. This was really strange. The patient, as I said, survived neurologically, and we believe that this was the first, in fact, it's been said by others, this is the first arterial blood gas demonstrating the metabolic effects of what must certainly have been malignant hyperpyrexia. This is a diagram which defines the change in temperature. These were not continuous measurements, so they're having an intact line, an uninterrupted line. It's not accurate exactly, but you can see how the temperature went up and then down. The first pH was detected at 6.8 and was restored to normal fairly quickly, and the hypercarbia was treated. We published a paper in JAMA entitled it Hyperthermia During Anesthesia. The term malignant hyperpyrexia had not yet been discovered or not yet been used, and cases of malignant hyperpyrexia were only now beginning to be reported, and most of them required both a combination of halothane and succinylcholine. The blood gas measurements that were made were performed with the blood gas apparatus that Freeman Bradley and John Severinghaus had produced. It was in the laboratory at the time this patient was ill. I'm going to take a slight diversion from this discussion of Ted and I and stuff that went on at Cal for just a minute, because this case of the hyperparexia occurring in a patient that received unnecessarily 4 hours of anesthesia has troubled me then and has continued to trouble me. Remember, this occurred in the early to mid-60s before the advent of mandatory IRBs, and pre-op discussions were hardly very detailed. You would go and pretty much tell a patient what was going to happen, as opposed to explaining in great detail and asking them if they had any questions. A paper published in 1966 by Henry Beecher, who I believe was Keith Miller's chairman at the time, and Keith will be speaking to you later on today. It was entitled Ethics and Clinical Research. And maybe it's a little bit of hype, but I think this might be considered by some as the most important clinical research paper ever. It's certainly widely considered instrumental in establishing NIH require approval by local IRBs for human experimentation funded by the NIH. Beecher said, quote, "Evidence is at hand that many of the patients never had the risk satisfactorily explained to them, and it seems obvious that further hundreds have not known that they were the subjects of an experiment, although grave consequences have been suffered as a direct result of experiments described here." He studied 100 consecutive human papers published in 1964 in, quote, an excellent journal. 12 of these papers seemed, in his opinion, to be unethical. He commented that, quote, "in many of the examples presented, the investigators have risked the health or the life of their subjects." And remember, our Group D patients were anesthetized for 4 hours unnecessarily prior to the advent of surgery, without, in all honesty, a detailed description of why it was being done. Some examples of Beecher's commented on was a dose-ranging study of chloramphenicol, chloromycetin, a known cause of aplastic anemia, and the patients received 2 or 6 grams per day. Toxic bone marrow depression occurred in 2 of the 20 receiving the small dose, and 18 of the 21 getting the larger dose. The smaller dose was recommended. The second was to determine the period of infectivity of infectious hepatitis. Artificial induction of hepatitis was carried out in an institution for mentally defective children. And remember, this is 20 years after the Nuremberg trials. Live liver cancer cells were injected into 22 hospitalized patients, told that they would be receiving, quote, some cells. And Lynn, you might be interested in this one, melanoma transplanted from a moribund daughter into an informed mother in hope of better understanding of cancer immunity. The daughter died the next day. The mother died a year and a half later of metastatic melanoma. Henrik Ben Dixon, my former chair at UCSD, suggested, and a colleague of Beecher's at MGH, suggested, in fact, because he disagreed with the intent of this paper, suggested that consent was implied when the patient entered the hospital. Beecher, on the other hand, said studies studied were limited to those performed for the, quote, benefit of science in general, rather than for the subject of the experimentation. And this paper and these comments have really impressed me that perhaps some of the science that was being done in the early to mid-60s was not appropriately vetted. In my opinion, back to Ted, the lasting legacy of a mentor, as much as the quality of his or her research, is the product of the students. What have the students done? What have Eager's students done? Well, it turns out they've done quite a bit. 2 became medical school deans. 4, in addition to Ted, received the ASA's Distinguished Service Award. 4, in addition to Ted, received the ASA Excellence in Research Award. 2 became editors of anesthesiology. 2 became editors of anesthesia and analgesia. 4 were now directors of the American Board of Anesthesiology, and 24 went on to become department chairs of U.S. Departments of Anesthesiology. Ted's influence on the specialty in terms of his science, I think, is quite impressive, and it's for mostly very clinically oriented. Provided an easily understood description of uptake and distribution of inhaled agents. He described MAC as a standard of equal potency, the effect of nitrous oxide on gas spaces within the body, the comparative effects of all volatile anesthetics on ventilation and circulation, primary investigations of the clinical pharmacology of the most commonly used inhaled agents, including isoflurane, enflurane, and his love, desflurane, and the fundamental observations on the mechanisms underlying the action of anesthetics, and I believe Rod Eichenhoff and Keith Miller are going to talk about this later. The influence on the specialty in terms of his research fellows, many of them have gone on to have independent research careers, and I made some attempt to catalog or count the number of papers, and it was several years ago, it was greater than 1,600 publications. He was one of only 2 individuals, the second being Jack Mischenfelder, to have been awarded both the Distinguished Service Award and the Excellence in Research Award. Several years ago, toward the end of Ted's scientific career, he and I engaged Rod Westhorpe from Melbourne, Australia, to put together a book on the history of anesthesia. This is a cover of the book, and it consists of 2 components, actually. The history of anesthesia described in the 15 chapters that were written by Rod and I and Ted. And then we engaged 100 additional authors, some of whom are in the audience today, including George Gregory and John Severinghaus, to provide chapters on the various subsections of anesthesia. We also asked the editors-in-chief of the 16 most important anesthesia-related journals to supply a short essay predicting their respective visions of local or worldwide anesthesia 10 years hence, in that case in 2023. We started this project in 2008. The book was finally published in 2014. Each was asked to ignore the great risk of being wrong. There were 2 groups. They were divided into 2 groups. We described them as pessimists who really did not have much hope for the specialty or were a little negative in terms of the way it would end up, and the optimists. The pessimists said there was going to be less support for research and clinical enterprises, with a resulting decrease in development of new information and new investigators essential to academia. Some evidence is already occurring with the so-called sequester that our government has implemented. There would be fewer of any new drugs or devices, and there would be shortages of highly trained professionals and increasing clinical demands that will force reliance on less expensive anesthetists with more limited training to give clinical anesthesia to older, sicker, and fatter patients. This is a description of the number of new drugs that were added by various decades, and you can see that the 2000s had very few and only The new, and what's the new antagonist? Is pretty much the only new Sugammadex, which I've never used. The only drug that's been developed in that period. The pessimists continue to sustain the safety that modern anesthesia has so carefully cultivated will mandate anesthesia dictated by mind-numbing checklists. And certainly checklists have occurred. I happen to think that they're probably an advantage rather than a disadvantage. And departments of anesthesia may be subsumed by larger enterprises, losing the name anesthesia completely, and programs dictated by someone with no immediate expertise in anesthesia. Grumper, watch out. The optimists, on the other hand, said that anesthesiologists will be the leaders of perioperative medicine, from admission through procedure, post-op care, and home, also known as the surgical home. The clinical research will increasingly shift to multi-center long-term outcomes research, as well as concentrating on what are now known as big data. And finally, we will continue to control the management of acute pain. With that advantage, compete with other specialties for the management of chronic pain. I want to conclude with a personal perspective. Ted and I have been fortunate to have been part of this odyssey for most of the 60 years, during which the specialty has morphed from one of empiricism and the effect of A on B to the how and why things work the way they do. Anesthesia has changed from a specialty generating disparaging comments to one attracting the best and brightest of our graduates and growing influence at all levels of medicine in the country and is in fact much of the world. Just imagine the experience and challenge of beginning a career as what was known as an etherist and ending it using a video laryngoscope and an ultrasound probe as a member of a department of perioperative medicine. One aspect of my career that has made leading clinical medicine so difficult, and I retired 5 years ago, has not changed, and that is the wonder of anesthesia and the amazing sensation that occurs after you're telling your patient, just take a few breaths or count backwards, while you inject a drug allowing you to assume responsibility for that patient's very existence. Few physicians can ever appreciate how addictive that can be, and to some extent that mirrors Eager's description of why he went into anesthesia. In 1975, I was co-opted to go on a trek 200 miles of the John Muir Trail. I had never carried a backpack in my life. There was a third person, Dory Eager. She joined us on this. And I can tell you that it was, in some respects, an exhilarating experience, but I quit after 50 miles and went home with a terrible case of bilateral Achilles tendonitis. Thank you so much.